my God, this is a question of the century. I've had really severe anxiety and depression my entire life, even since I was little, and I've always questioned this. Mental illness runs on the side of my family that doesn't have Huntington's disease. My great grandmother actually committed suicide, and my aunt also committed suicide. So it's probably a mixture, but yeah, I honestly can't differentiate anything.
Ah, we've actually heard a lot about this online lately, but for the first question, is there a way to differentiate symptoms of Huntington's disease from other regular illnesses? And why don't we start with you, Dr. Frank?
Yeah, this comes up a lot in many contexts. Obviously, if someone has a cold, we don't attribute that to Huntington's disease, right? If there's a sudden decline, if all of a sudden people can't do something, that's typically not Huntington's disease. But it gets a little trickier when there is something like anxiety or depression. And if someone has had chronic issues with anxiety and depression since they were a teenager and now that they're in their 40s, it's unlikely that's related directly to chemical changes in the brain in that individual. It doesn't necessarily mean that there are other reasons to have an increased risk of anxiety or depression, like in this video, the other side of the family, right? But is that Huntington's disease 30 years of anxiety and depression? Probably not. If someone doesn't have any issues with depression or anxiety, and then all of a sudden at 40 has agoraphobia and they can't leave their house because of the degree of anxiety that they have, and it's been building up to that, and now their anxiety is so severe and it's happened over a year or two, that's something that is more likely to be related to Huntington's disease. So it's every time you read in the scientific literature, it says it's a neurodegenerative process. So degeneration means that it gets worse over time. And so something that's static is unlikely to be Huntington's disease, and things that change over time are more likely to be. And I always appreciate when a primary care provider, nurse practitioner, physician calls me up and says, is this Huntington's disease? Because I'm noticing this change, or there's this issue, or this has been going on for 30 years and now we need to address it. And having a conversation, because otherwise a primary care doctor is just going to assume it's Huntington's disease and chalk everything up to it. And that's not right either. Colds aren't caused by Huntington's disease, but sometimes anything and everything is attributed to Huntington's. Oh, you got to talk to your neurologist about that. Not everything. And so it's worth a conversation, and communication is important.
Awesome. Again, for Sam, when is it time to seek symptom management for someone who has tested positive for HD, but is just beginning to show symptoms?
So this is a conversation that we often have after people go through genetic testing. Once we find out that they are gene positive, we ask them, what's your preference? Do you want to touch base? And this is after the acute phase, right? I think that there are most centers that do good testing are going to follow up people in the short term, weeks, months. I'm talking a year after testing. And so what is the person's preference? Do they want to touch base every 6 months to see what's going on? Every year, just if they notice some symptoms? And I think that this is one of the main reasons to stay connected with a team that's familiar with Huntington's disease. A, so that those doors are open, and B, somebody's monitoring you over time. And so to be proactive about it is probably the best way to address some of that anxiety about, am I showing signs? Because then if something happens, you can get in touch with that neurologist that happens to be following you and say, I dropped a glass today. Is that Huntington's disease? And they can say, you were just in 2 weeks ago and I saw no signs, so it's probably not. And so I think that I don't think any of the team members that follow our patients and families with HD would be upset if you asked, is this HD? And have a conversation about it. But I think following people based on their preferences in terms of the interval and being proactive before it gets to that point usually can be helpful.
Even within the family, because this is really a family disease. So sometimes people who have this gene and may or may not be showing symptoms might not want to have treatment. But if there's an open conversation in the family to say, we need to have this talk. So you might not see that there's anything going on. We might talk about anosognosia in a little bit, but I do. And every time when we walk into the room, everyone's walking on eggshells. We need to have this conversation with the team. So I think it really is, it is certainly in what Sam was saying, but also within the family to say, we need to have that open, honest conversation with each other, because you might see something different than I do. It might not be anything, but also just to know that some of these symptoms, although we don't have disease modifying treatments, some of these symptoms are pretty easy to treat. So I think it's really about having that good relationship with the healthcare team and an open relationship in the family and good communication.
Yeah, that I have conversations with spouses or really good friends that come in with the patients of exactly that. If my patient will have a conversation and say, if your spouse or your best friend sees signs, do you want them to say something? Do you want me to say something? And so again, communication about that is really important, because the person outside the clinic is going to see them a whole lot more, especially if someone's gene positive, premotor manifest, and trying to live their life.
Thank you. This next one, maybe Bonnie can start off. Often in our community, we see that both sides of the family have mental health issues. For the children of these parents, is it common for them to also have depression, anxiety, suicide ideation, etc., regardless of their own gene status?
So when we talk about family, Huntington's disease, we know that this is a family disease. And when people grow up in families that there's a lot of dysfunction, or that there is difficulty, that one parent is having trouble taking care of the children, or that there is a lot of secrecy, or there might be self-medication through alcohol or drugs, there are going to be mental health issues. So I think it's really important that we recognize it doesn't have to be stamped with a diagnosis, but that there are lots of mental health issues that do happen in some of these families, whether it's the children, the well spouse, or even that person with the HD gene, but who doesn't have the diagnosis officially of Huntington's disease. So I think it's not a question of stamping someone with a diagnosis, but just saying, as we saw in a video before, that this gentleman was like, I feel like I have these symptoms. Does that person feel not only that they have movements, but they also have psychiatric symptoms? Because as Sam said earlier, a lot of these things are prevalent in our communities anyway. People are under stress tremendously, especially during the pandemic, and now what we're calling post-pandemic, that there's so much more anxiety and depression right now, that these things are going to come up. So I think it really is important to just know that it can be stressful growing up in a family with Huntington's disease, and being able to say, can I reach out to someone just to say, what can we do to help somebody? And as we saw, and I do have patients in our clinic who have come to us and said, I have anxiety, I have depression, I've been diagnosed with bipolar disorder, I have all these psychiatric issues going on, and we work with them. We get them to a place where they feel that they're comfortable if they want to be tested. And a lot of times they are negative. So we know that this is prevalent in the community, and that there are times that we're working with young people who feel that they have suicidal ideation, and they feel that they don't belong, or that they're not loved, or that they're neglected. So this is really important, because we need to get the support systems in there, and we need to be able to see if people do need help in these families.